Hey, friend, welcome to Grounded, the vestibular podcast. I'm Dr. Madison Oak, aka the Vertigo Doctor. I am the vestibular physical therapist who is here to help you with all things dizziness, imbalance, and vertigo. In this podcast, we explore the fascinating world of vestibular disorders. Come with me as we dive headfirst into a journey to discover the mysteries of the brain, the inner ear, and the balance mechanisms that keep us grounded. Whether you've been managing dizziness for one day or 25 years, we're going to get real about what it takes to manage dizziness, handle the anxiety cycle, and thrive, not just survive, with your vestibular disorder. First, I want to remind you that this is never medical advice. Remember, this podcast is for informational purposes only and may not be the best fit for you and your personal situation. It shall not be construed as medical advice. The information and education provided here is not intended or implied to supplement or replace professional medical treatment, advice, and or diagnosis. Always check with your own physician, medical professionals, and healthcare team before trying or implementing any information found here. Meet me in your coziest chair while we navigate the highs and lows, the twists and turns of the vestibular universe. Welcome to Grounded. Let's dive in. Hello, everyone. Welcome back to Grounded, the vestibular podcast. Dr. Jenna and I are here today. My name is Dr. Madison Oak. That is Dr. Jenna Green, my wonderful counterpart. And we're going to be talking about, do you need vestibular therapy or not? How do you know when to go? How do you know when to stop? All those things. You can be not ready for VRT. And I have
Ooh.
kicked multiple people out. Gas as a vestibular therapist. Kindly. I'm sure you have too.
Hey, I always say the person that has, it's obviously against maybe their, financial well-being or something to tell you you don't need it. And if they're saying it, like that's probably someone you want to trust and keep with. But there's always, that caveat of how's that conversation going? Because I know it might be there's nothing else I can do for you, or you're stuck like this. Like those type of conversations, that's not what I'm envisioning when we talk about this. And I know we haven't quite dove in yet, but typically, if someone's saying, hey, it might be best to hold off, maybe here's a plan, here's what I'm seeing that's making me think this based off what you're saying. And, as the patient, sometimes you have these conversations and they're like, I was kind of feeling this way too. I just wasn't quite sure how to bring it up, or I felt like I was quitting or a failure. And it's like, no, 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 no. Like, back up, back up, back up.
100%. So let's back up, you and me. I feel like we tend to get ahead of ourselves. What is vestibular rehab? I feel like most people might know this, but definitely not everyone. So I don't want to get into this without first explaining it. So, Dr. Jenna and myself, we are vestibular therapists, which means we are physical therapists. We have our clinical doctorates in physical therapy. We graduated physical therapy school. And when you graduate PT school, you become a generalist. There's no one specific thing that you are required to do. So some people in PT might go for continued like residency style 1 year trainings in a very specific field. We don't really have that for vestibular. We have different continuing education that you can do. You can work at a vestibular clinic, but there are certain things in PT, like you can get a sports one or I don't know, there's a pediatric one. There's all these different like things you can go and specialize in if you want to, but it's not a requirement like it is for medical school, which is kind of a big draw for being a physical therapist because you can change your career trajectory and what kind of PT you want to practice relatively easily. So,
Yeah.
yeah, which is kind of
I was like,
cool.
I agree. And I know
Mhm.
sometimes on, the flip side of that is just because you do or don't have that title doesn't always mean you're going to be a good or bad fit type of thing. Like
Mhm.
if they're like a lot of people in vestibular world maybe are like have a neuro residency or are
Mhm.
certified by the neurology as a neurology PT, and they're really smart. They know a lot of things. I don't have that, but I still feel like, hey, I can do a good job with vestibular, even though I don't
Mhm.
have that additional background. Like some people have horrible experiences, even though people have all these,
Mhm.
letters after their name. So it's nice. It's one way to try to help narrow a search, but sometimes, again, this boils down to the person that you're sitting in front of.
Absolutely. I think like having a good relationship with your physical therapist is so important and feeling like you're able to tell them things. Like I try to be the most receptive of all information as possible, but still not everyone's a good fit and that's okay. But kind of like you were saying, the closest thing that a physical therapist can get to being like a having a, I don't know, clinical specialist letters after your name, like NCS for neurological clinical specialist, is a neurological clinical specialist. And there are some NCSs who are awesome vestibular therapists, but there are also some people with NCS after their name who only treat stroke and spinal cord injury. And so you really have no way of knowing just from their credentials if they are a good vestibular therapist. So we both have a clinical it's called CCVR. It's a certificate of competency in vestibular rehab. It's one of the certificates you can get. There are like 3 or 4 main big ones that you can get for being a vestibular therapist, but it doesn't necessarily put more letters after your name, which is a little bit confusing, but it does tell you, "Hey, I've been trained in vestibular therapy specifically." So that's kind of our background on that. We also had internships at very specific, excellent clinical clinical rotations at excellent institutions almost of vestibular rehab. So that is how we became vestibular therapists. But what is vestibular therapy? It is basically the specialty of physical therapy that helps you with vestibular disorders of kind of all kinds. So sort of like you would see a spinal cord injury physical therapist for a spinal cord injury, you would see a shoulder or orthopedic physical therapist for a shoulder injury. You would see a vestibular physical therapist for a vestibular disorder. And just like every single kind of physical therapist, there are ones who are better at this than others, and that's okay. Not everyone has to be good at everything. I always say if you have a knee injury or a shoulder injury, please do not call me. Like, I literally don't know what to do with you anymore. So, we have gotten really good at only treating vestibular disorders. And if you are dizzy, we are the people to help you, someone who is a vestibular therapist. Vestibular therapy itself is a very, very, very broad spectrum of things that we can do. We can treat BPPV with an Epley maneuver, which most physical therapists overall know how to do. And we can also treat vestibular migraine with lifestyle changes. So there's lots of variation in the different kinds of exercises we can prescribe and the different kinds of things that we can treat. But just like in orthopedic physical therapy, there might be people who are better at shoulders than they are at knees. There are also people who are better at vestibular migraine than are at just doing BPPV or something like that. So you really want to dig down into who you're seeing because I have seen plenty of people who are going to vestibular rehab who I ask like they're like why didn't it work? I'm like what was your program? And they're like I did 3 times 10 sit to stands from a chair and then I did some bicep curls and then like I closed my eyes for a minute. And it's like that's not vestibular rehab. That seems like you're treating an orthopedic injury to me. Like yes, technically that could work on your balance in theory, but like that's not what I would classify as typical vestibular rehab. So knowing what you're getting into and trusting your gut is typically a good like baseline for finding a vestibular therapist.
Yeah, and I mean, I know sometimes access is a whole other thing, and nowadays I know too you can kind of like look up your therapist ahead of time online, and they might have a little bio of what they're interested in or what they like treating or what they tend to treat more of. So again, sometimes those can be one way to help too. Or again, if maybe you're in a small town, there's like the one PT, you might just say, how familiar are you with this? How comfortable are you with it? Because, like you said, in general, like baseline generalist PT, everyone should be able to assess and treat BPPV. Now, that's different than I've been a PT for 20 years. I've seen it like once, and like, how comfortable am I doing it though? Because we're still people and we don't want to, feel like we're not doing the best job that we can for a person in front of us in that state. If they have BPPV, they're like, there's probably someone better. I don't want to be the one to do it. So sometimes there's that whole thing too. Like we're still people, we want to help
Totally.
other people. And if we're not comfortable with it, it's hard for us to be like, yeah, let me just let's try it, like
Totally, totally. I think that there's also, like, some people will phone a friend, like, we all have at least one colleague who does this specific thing now, and I get other PTs who I've never met before reach out to me, be like, "What do you think about this? I'm in a really rural area, what do I do?" And so a kind of PT who's willing to work with you and learn with you is better than the best PT who refuses to know anything about you. So I would say, like, if you are in a rural area and you can talk to your PT and be like, look, I have this condition. It's let's say it's a rarer one. It's not something you treat often, but like, could you do some research for me? Could you reach out to some people? Could you maybe take a continuing education class in it? That sort of a thing and learn with me. I will also do my research on my end about things that I think could help me, but can you also do that? That's an also a good person to maybe go and see.
yeah, I think yeah, some people might just try to like smile, fake it till you make it type of thing. I'm very much a I don't really know. I'm going to tell you up front. I'll do my best, and here's what my best might entail. And if you want someone more sure of themselves, then we're not going to be the best fit. And hopefully, that person that shows all this confidence and whatnot, like really is a good fit, and they really are giving you the best option. And again,
Mhm.
it's never always a guarantee. It's always what you feel most comfortable with and
Totally.
what options you have.
Totally. So the symptoms that you should see a vestibular therapist for would be dizziness and imbalance, which I feel like are the most like straightforward ones. But other things that you can see a PT for are also motion sensitivity, sometimes ringing in your ears or tinnitus, however you want to say it, ear fullness and pressure, nausea and vomiting, fatigue, brain fog and concentration difficulties, anxiety, and depression. All of these things can be covered in vestibular rehab. Now, for the anxiety and depression component, yes, we can sort of help with this because we can give you more confidence in being able to move about your life and kind of be able to do the things that you want slash need to do. But we are not cognitive behavioral specialists. So there's kind of a fine line there, but all of those things can be related to your inner ear and vestibular systems and things that we can help with.
Yeah, those ones when they're put on that list, I go, that's it's getting to the core of it. Like I feel on edge because I don't understand why when I lay down or move my head, I get this spinning out of nowhere. It's like, okay, well, oh, look, it's BPPV. Let's treat the BPPV. That should help start bringing back that confidence. Now, if it's more of this, hey, I'm barely washing my hair because I don't want to tip my head back. And it's been 7 months or couple months since we've done a BPPV treatment. Things are still clear, but I just like have this feeling that it's just like, how do I know what if it comes back? Like, if it's really still impacting you, like, yeah, that's outside my realm of trying to help address that anxiety, right? Like,
Totally.
that's a very normal, valid response to things like that. A lot of people ask, well, how do I know it's not going to come back? Or, like, you know, that little voice that it can come back. It's like, you're not the first person that's brought this up. I wish I had a better answer.
Mhm.
And here's what we can try to plan for.
Absolutely. So I think that people always want to know what is the timeline? Like, why don't I feel better yet? Or when should I be feeling better? And I really want you to know that it really varies by person to person. So let's say you are qualified and ready for VRT. Let's say you have a vestibular neuritis and the acute phase, that first 3 days is like over, and you're not like the room isn't spinning 24/7 anymore, but you feel dizzy, imbalanced, have difficulty in dark spaces, classic peripheral unilateral weakness of your vestibular system. Typically, people will start to feel differences maybe in 1 to 2 weeks. Typically, at like that 4 to 6 week mark, you'll start noticing progress. And we really need to do an episode on how to measure progress because progress does not necessarily mean I am not dizzy anymore. Progress can mean I can walk in a straight line again. Progress could mean I can go to the grocery store for 10 minutes instead of 2 minutes. Progress really can mean a lot of different things. So, that sort of progress should be noticeable within 4 to 6 weeks. And if not, you're going to want to reevaluate. But I have seen people a year and a half, not every week. I also don't believe in typically seeing people more than once a week or even more than like twice a month for some people. So
Mhm.
seeing them for longer times because VRT is about what you do at home. It is not about what I can see you do in the clinic over and over and over again. Unless you're the kind of person who you're like, I have to go to the clinic because I know I'm not going to do my exercises. So I need to be there 5 days a week. Fine. But most people I see twice a month max, typically. So
Yeah.
yeah, so that's something to consider as well as a
I
general
think
timeline.
I think, yeah, when it comes to vestibular therapy, it might just be again, where are you at? So if they are like, I have no idea what this is. No one's told me anything. They just gave me meclizine and the script and out the door. I went kind of thing for PT. Then it's like, all right, maybe 1 or 2 visits in a week. That might be the like more of that scenario when I would see that because you just want to spend a lot more time educating up front and then more of a weekly thing to again my goal is to educate and have you be able to feel comfortable and confident in assessing how am I doing is maybe this means I overdid it and then because we've talked about this I know how to do these adjustments so the goal is that you're able to start being able to adjust and pull back or move forward on your own start spreading out those visits to say, hey, this is getting easier. I'm not quite sure where the next step should be now. Like, all right, let's come up with some different ways to help keep you going to that next phase.
Totally. I think the first couple of visits, really heavy education. I'm totally with you. Seeing you weekly. And then after that, really tapering it off pretty quickly. And then check ins, I am 100% on board with. I know a lot of people who are in VRT 2, 3 times a week. And that gets expensive even with insurance if you've not yet hit your deductible. That is going to cost you the same, if not more, than paying cash for your PT. There's math on that. Anyways, I think it's important to recognize that typically that is not required, and that may or may not be a less experienced therapist if that is your protocol. And again, if you are like, I'm super happy and comfy doing twice a week, every week for 6 weeks, that's fine. There's nothing wrong with that. But if your insurance is giving you 12 visits, I think that your therapist could likely be smarter with your schedule. Likely. So, general timeline, I think, yeah, you should be seeing differences in your function at least by the 6 week mark. And if there's absolutely no differences, it's my job, it's Dr. Jenna's job to go back to the drawing board and say, like, what have I misevaluated? What have I missed? What do I need to kind of rethink in order to get you back to that spot where we should be progressing pretty solid by that point?
Yep. And I'd say sometimes, again, I know when it comes to clinic systems, like your insurance only approves it for 90 days. And then it's like you have to go back to the doctor to get the prior auth. So I know like what we're saying is not always what you can get in more of those, formalized clinic settings. And I don't think it's too much of a surprise that that's not where we're working.
Insurance should not dictate your healthcare, but it does. So if it
Like,
does, there are always things that you could maybe try, some loopholes, but that's
like,
why you see less and less physical therapists working with insurance because it doesn't pay, but that's a whole other thing. It literally dictates what we can and cannot do in your session. It's just like your doctor prescribes you Nurtec and the insurance company is like, no, I'm not giving you that. It's like my doctor said, it's like they don't care. It's too expensive. So these are all like in a perfect scenario, this is what I would do, but of course there's always different requirements for each person.
yeah. So I know we've both been in environments to understand that what we're saying now, our ideal is why we're doing it this way, and that there are different barriers and different things going on behind, like, if it's twice a week or they can't push it to once a month or they can only do once a month for how long or all the goals are met even though you're not quite where you wanna be, but they're saying there's nothing else we can do. It's like that again might not be on them and them being like a bad person or a bad therapist. They're kind of in this institution too where it's like, I wanna do it, but they're not gonna let me do it.
Mhm. It's true. It's true. So, backing up again, I feel like we've been doing like a forwards rewind
That's how you best learn
situation.
information.
Is it?
Just
I'm going with
reviewing.
yes. Oh, reviewing.
Hearing
Okay.
about it.
Yes,
Yeah,
I like it.
we're reviewing.
So, can you start VRT too soon? So, can you start vestibular rehab therapy, which is way too much of like gobbledygook in your mouth? So, VRT, can you start it too soon? Is it possible to be not ready? I feel like we talked about this a little bit at the beginning, but I want to be really specific about it. The answer is yes.
Absolutely.
And this is where we both have like very gently and kindly kicked people out of VRT before. Because there are better things that you can do with your time, frankly, with your money, with your deductible, with your insurance, with your life to feel better without VRT a lot of the time. And this idea is where vestibular group fit stemmed from, which we also need to do an episode on. This is where this idea came from. Because if you are in a place where like the slightest head turn triggers you for a whole day, or you can barely get off the couch, or you are so dizzy that like someone coming to your house is overwhelming and makes you nauseous and causes symptoms. These are all places where this is likely in a state where you are not in a well controlled vestibular state. This is especially true for people with vestibular migraine. And if you're listening to this, vestibular migraine is the most common cause of neurological dizziness and vertigo. And I read some research the other day to show that it is now competing for the most common cause, more common than BPPV. It's not quite there yet, but it's getting there.
Ooh.
So it is like really way more common than we think. I'll send you the article. It's fascinating. So it's really getting up there. And I'm like been doing some math to see when it's gonna kind of go over that threshold. But especially with vestibular migraine, that can be really not controlled. You could be having daily attacks that you don't have anything to do about. You don't have medication, you don't have supplements, you don't have these lifestyle changes that you need. You don't have different techniques to make this feel better. You're just like, this is out of control and I don't know what to do. That is not the time to start traditional VRT. And by traditional VRT, I mean the kind that you see on the internet that's like shaking your head all around, putting on optokinetic stripes, which are like the moving stripes in virtual reality goggles, sticking you in the grocery store and seeing what will happen. That is not the time. And I speak to this from a place of experience. I have done this to patients before. I do not feel ashamed. Well, I do feel ashamed of that now, knowing what I know now, but I'm not ashamed to admit it because I think that like one of the most pivotal learning experiences for me as a physical therapist was I was a new grad. I was a new grad. I got these patients. No one at the clinic I worked at, not no one, but they preferred to treat acute dizziness. And I was like, I guess I'll treat the chronic dizziness patients. And I would just like send them home shaking their heads and they'd be like, I am so much worse. And I'd be like, why? This is so bizarre. Like I've treated so much vestibular neuritis. And then I like really dove into the vestibular migraine research. And I was like, oh my God, I understand migraine now, which I think that we still don't understand enough of it, but like enough as I could at that point. And I was like, "Oh my god, these patients need XYZ instead." And so as a physical therapist, I shifted what I gave my patients and they started getting better. And I was like, "Oh, big, big turning point there." So in those cases where VRT feels too soon, we really want to start with the basics because shaking your head all around is more than likely going to make you feel worse in those instances.
Yes, and I remember, gosh, I think there's like the vestibular like SIG with the APTA. They were
Mhm.
I think it's free. I'm not a member, so it must have been if I was listening to it or someone was already logged in and let me listen. I don't know. But there was this one therapist that has been, doing this for a while and was like, if they're migraine, I don't see them until they have seen like a neurologist and
Mhm.
have been given like a rescue medication or if they have a preventative that they've been on it for like 2 months. Like I
Mhm.
want them to like go through that, go through the like migraine management and have at least a couple months to get that like at least partially on the way to getting figured out before we even do anything. Because
Mhm.
until they get some sort of a foundation like that, if we're just flaring them up, having it take days to recover, like, you're just starting over again. It's hard to build off of that when there's this boom
Mhm.
bust cycle going on.
Totally. And back to the neuroplasticity episode we recorded, like, if you go listen to that, you're gonna learn more about why this is important because your body needs to understand, "Hey, I am safe, and this isn't gonna be so triggering that it ruins my whole day." And I'm not saying that you're never gonna have a vestibular migraine attack again. It's probably if you live with vestibular migraine, you're probably gonna have an attack again because there are no cures for this. But you can get to a point where stuff and life is less triggering. And when you do have something that's triggering, you know what to do about it. I have a rescue medication. I take extra magnesium. I go for a walk. I do breathing exercises. I do cold therapy. I put ice on my neck. I do gamma core. Like whatever that thing is for you. That was like 100 things. Don't start all at once, please. But building up this toolbox slowly but surely is going to be what is so, so important. So we call them the basics in vestibular group fit. And if you don't know, Jenna is my work wife in vestibular group fit. And we together have sort of discovered what the most helpful things are and kind of getting back to those basics. And I will tell you right off the bat what they are. Eating and hydration, keeping your blood sugar level, keeping hydrated throughout the day, super important. Getting enough sleep, gently moving your body, and breathing, meditation, grounding, some sort of mindset work. If you can do those 4 things really well, not everything is gonna, like, be perfect rainbows, butterflies, happy-go-lucky all the time, no, but that is going to give your body a sense of calm, a sense of, "Hey, I know what to do. I know when to do it. I know what it looks like for me to feel a little bit safer in this situation. I know what that looks like." And understanding that and having those things that you can do, again, that's not going to make it so you never have an attack again. It's not going to make it so every attack goes away instantaneously, but it is going to give you a sense of self and a sense of calm and a connection with yourself that it's like, hey, I can do this. I can be okay. I know it. Kelly Yates of the migraine dietitian, she said her motto for migraine is it came so it can go. And when you have these different tools, that makes it so much more helpful. And that's when vestibular rehab can really do its thing. I will say, I do make exceptions for some patients. And there are always going to be exceptions to the rule. We do not have to go down a rabbit hole about every exception I've ever made for new vestibular migraine patients. But if you're like, I need someone to walk me through this, and my local physical therapist, or you want to see Dr. Jenna or myself in the states we're licensed in, we can see you from day one, but we're not going to be doing what you think of as vestibular rehab. We're going to be walking you through different ways to eat and sleep hygiene and hydration and critical thinking and breathing and grounding and tools you can use and links for things you can buy if you want them and all that kind of thing rather than can we shake your head to a metronome at 120 beats per minute to 240 beats per minute because those are
100
way
120 halftime.
120 half time exactly. So it's like maybe we shouldn't start with those things.
Yeah,
Let's start with the other things.
I think like what you said, like, here's 4 things, you could list it out like boom, 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 here you
Mhm,
go, like, that might be something I give to someone as like here's like a little summary of just like sleep is like, here are the basics, right? But within
mhm,
each of those, again, everyone has a different experience and comfort level with that of like, I'm not like, okay, lifestyle changes the basics, but where do I go from there? What does that look like for me in my life? And that's
mhm,
where, okay, you're in this more like fragile boom bust state. Let's just try to break this down more. Let's just find, the lowest hanging fruit. What's something we could work on? And maybe
Mhm.
it's hydration. Like, great.
Mhm. Totally.
Do you
Choose
have a
one thing.
do you have a water bottle? They're very in style now, the emotional support water bottle, I feel like I've seen.
I have
Like
like 12 emotional I clearly need a lot of emotional support. I have like 12 emotional support water bottles, honestly. So,
like,
wha
picking things out like that, like, okay,
yeah.
let's and again, sometimes it's not that, like, again, these we say that they're basics, but it's more of these, like, here's something you can start working into your life now. The barrier cost to entry is a little bit lower,
Mhm.
right? It's not super paved, easy peasy
Mhm.
to do, right? Otherwise, maybe you've already would have been doing it, but it's easier than having to, you know, go hours away to find a specialist or get your insurance to approve this medication. Like, what's
Mhm.
something that you could like start that day or the next day? And that's why they're called the basics.
Totally.
Um,
Totally.
so usually that might be why where some of these other visits are coming from, where it's like we're not doing a single exercise that you've probably seen on some sort of vestibular or dizzy account. Like
Mhm.
we are talking, we are brainstorming, we're like
Mhm.
probably making like a Target order list in
Mhm.
Minnesota, right? Like
Totally. Totally.
or
I'm
YouTube video links or Spotify playlists. Like different
yeah,
things because again, that's how we're trying to find again the lower barrier to entry.
100%.
And
100%.
sometimes you might know it, you might be able to do it yourself or find this research out there. Like it's not like this golden secret thing,
We're not
but
gatekeeping.
sometimes just I know I have someone that I can lean on and ask and reach out to or can help make some of these decisions because I feel like crap and I don't want to make all these
Mhm.
decisions to decide where to start. That's where we're coming in.
Mhm. 100%. Okay.
Uh,
So, once you've done these basics, if you were gently asked to not do VRT yet, when are we ready
oh
to
wait, can
get
I
to VRT?
interject?
Yes.
So I know we were talking about all that stuff, like you said, like vestibular migraine to start
Mhm.
with, right?
Mhm.
Um, I feel like this could just apply to everyone and anyone in
Mhm.
general.
Oh, yeah. No, these rules apply to everyone. I agree. I totally
That was
agree.
my thought. It was obviously life changing.
It was life-changing for me, Jenner.
Yeah, just like
Totally.
I know VM tends to be the one that we'll see where it's like, hey, I think we just need to lay some groundwork here before we start doing anything that's a little bit more challenging and targeting to that vestibular system. Like, we aren't
Mhm.
going to be like, oh, you had a neuritis, just start with the basics and we'll see you in like 3 weeks. Like, no, we'll
Mhm.
want to try to get you started on
Yeah.
things. But if you're kind of in this, like, feeling like you're in this no man land twilight zone thing, this is probably where we're going to start first.
Yeah. And you can always get an evaluation, right?
Mhm.
You can always go to the PT and be like, I just want to know if I'm ready for this or not. I want to know, like, from other people you've seen, is this a good starting point or should I start elsewhere? Because
Yeah.
it's not a bad thing. And if,
Get your
like,
foot in
if
the door,
Mhm.
like, whatever
Exactly,
it needs to be,
it's
like
easier to have a follow-up visit than it is to have an initial evaluation. So that is a good place to start. And then if you're having so much anxiety and health anxiety and issues kind of managing your mindset, sometimes going to classic cognitive behavioral therapy style therapy before you start VRT can be super helpful as well.
yeah, so I feel like sometimes, again, like, if you're, "Hey, there's a really long wait," or I am still usually it's like, "Hey, I'm just waiting to get to this next step, like, what could I be doing?" It's like,
Mhm.
give yourself a good foundation, give your body, your brain, all the support it
Mhm.
can to learn and adapt and do its best once you get to that point, so I know it might
Mhm.
not always sound like much, or people might be like, I'm doing all these things, but I want to do more. I want to be more proactive about this until I can get to that point. But sometimes it's time is the proactive thing, right? Like you
Mhm.
need to just give your body time to start absorbing this and letting it like take a nice root, right?
Totally. 100%.
And
Okay.
I've had people come in that are just like, I'm like, "I don't think you're ready." They are like, "I don't know if I'm ready either." I just again, they just want the eval, they wanna get a rundown, and maybe the plan is, yeah, come back in a couple months after these other things are done, and then you're on the same page and
Mhm.
they're in the system, like you said.
Totally. Totally. So once you are ready to go to VRT, there are a couple things that you want to look for. So, what is your average baseline of dizziness? So, kind of that like 5 out of 10. If 10 is like, this is so bad, I have to go to the ER right now, and 0 is, I feel fine. 5 is kind of that middle ground that gives us space to increase symptoms with head movement exercises, with functional exercises, whatever your goals are, but also return to baseline. So you should be given, like, first things first, how to breathe, how to ground, how to come back to baseline when your symptoms do flare. Because vestibular rehab, I don't say it's going to get worse before it gets better, but the intention of VRT is to provoke your symptoms a little bit, make you feel your symptoms, and then tell your brain, hey, it's safe to feel this, and bring that back down. That's the intention of VRT. That's what we do. And so when we think about that, it's like, do I have the space to increase those symptoms when I have them? If I'm already at a 10, the answer is no. But I'm at that 5 and I can go up to, I don't know, 6, 7, 8 range and then come back down to a 5 afterwards. That is really important. But you do want to consider how dizzy you get getting to the clinic, staying there for 30, 45 minutes, and then getting home. And that's why we believe so strongly in telehealth BRT, because you don't have to come to my clinic. You don't have to like run the marathon to the clinic, do rehab, and run a marathon home kind of a thing. So if you can get your PT to do telehealth, if you get car sick, if you get motion sick, if being in the car is a problem, ask them if you can do telehealth. And if not, find yourself a telehealth therapist like Dr. Jenna or myself.
Yes, I like to say, we're like flirting with fire, we're poking the bear. We don't wanna wake them up. We don't wanna, like, douse gasoline on it, but maybe we just have, like, the little can of bug spray and we're just like into the fire. Like, I don't know if you had any, like, pyro siblings growing up, but
Clearly you did.
yes, I have a story about that, but we don't need to talk about it. But yeah, it's like we need to, aggravate things a little bit. That's how we're stressing that system. Our brain is getting a challenge and our brain isn't going to change unless we kind of give it that push too. So this is the way our brain is saying, this is hard. I don't understand. This is aggravating, but we want to just do it enough so it can say, hey, what's going on? And then give it that space to calm down, settle back down so our brain can go, hey, this isn't going away. We better figure it out. So that's a very different take than like it needs to get worse before it gets better, because then that just sounds like we're like barreling through and just flaring everything up. So with that, we like to always kind of keep in, I think we were taught like the 15-minute rule, right? At
Yeah.
the clinic we were at different times. But
Mhm.
I sometimes just say, 15 to 20.
Totally.
I don't think 20 is too big of a jump. And sometimes, depending on the person, that area of exception, like maybe 15 isn't really that reasonable recovery time. Maybe it is 20 where it's like, okay, maybe your symptoms kind of get intense a little bit faster. So we need to allow a little bit more time for them recover to get into this working space.
Mhm. And I will also say with that rule that there are some people who are like, "I feel fine completely in rehab." And then I leave and I go home, and at the end of the day, I feel so much worse on the days I do my exercises than on the days I don't. And that doesn't mean anything is like worse or better than the people who get immediately dizzy. It means that you are more of like a threshold person, so all that means is that you are doing lots of things throughout your day, and adding in this extra activity is problematic for you. And so you need to take away something else. So let's say you do less dishes or do less house chores or do less work or whatever it is, drive less far on the days that you do rehab, because you need to now make space for that. So at the end of the day, your brain is not just exhausted, because that's not helpful either. There's a very, very fine line between these two things.
Yes, and again, I think that's why it's still nice to have that little bit of a gap between visits, or, at least have them spaced out a couple days, because even though we're knowledgeable, we're comfortable, we've seen more people with vestibular conditions, everyone is a little different, and it's a little bit of a detective work to figure out how your body responds. What
Mhm.
are maybe some of those warning signs of, like, oh, I never noticed that this kind of like tingly, prickly, whatever thing might actually be connected to my body
Mhm.
saying we got to take it easy, or I might have this flared the next day.
Totally.
So that's why I think having a little bit more of that breathing room to try to help figure that out, so I can try to do better to not assign something or give a rep or a dose that's too much, and they have the time to try to get a better feel of what might feel like too much as well.
Totally, and I think I actually I know. I get so many DMs and so many emails that say, "Dr. Madison, I did my exercises and now I feel worse and I don't know what to do." I'm like, "Well, did you email your physical therapist?" They're like, "No." Your physical therapist, most physical therapists are highly empathetic, very kind people, and they want to know if you are feeling a certain way about your exercises. I tell every single one of my patients on the first day of rehab, I want this to be a collaborative experience. And every single thing that you do, if you feel like, hey, I hate this exercise and I never want to do it again. If you say, this made me feel worse for 3 days. I want to know now. I don't want to know in 2 weeks when I see you. I don't want to know next month or next week when I see you. I want to know today. Send me an email, shoot me a text, put it on the messenger portal we have as like a patient client relationship. Any of those things are fine, and I guarantee you your physical therapist feels the same way because as a PT, it's pretty easy for us to adjust things over the phone. So if I give you a call or send you an email or whatever, I can say like, "Oh, do 3 of these instead of 10 of these or do this for 10 seconds instead of 60 seconds and let me know how it feels tomorrow." And there are just so many ways you can adjust this. And so you're welcome to DM me. I will always DM you back. But before you do that, DM your PT too because they want to know. I promise you they want to know. Leave them a message, call the charge nurse, however your healthcare facility works. Let them know as soon as you possibly can.
Yep, my favorite thing is, if you hate it, tell me. If you're
Yep.
like, "I don't see the point and I'm not gonna do this," I was like, "It's not hurting my feelings as a
No.
human if you tell me you think this is a dumb idea."
I agree.
Even if I thought of it, maybe I didn't actually think of it, maybe I just was like, "Let's just see how this goes." Like, it's not gonna hurt. I am secure in myself as a person. Like, it is
Yeah.
okay if you just flat out say, "This is dumb. I don't wanna do it. I don't think it's gonna be helpful." And I'll
Mhm.
either be like, "Here's why I think this might be worth a try, and if you don't notice any improvements in a week or 2, fine, twist my arm, we'll change it," or, "Okay, fine, let's try something else. Maybe we come
Mhm.
back to this if we feel like we've kind of exhausted options, and maybe education, whatever it may
Mhm.
be, it's starting to feel more appropriate again." Like,
Yeah, I
and
totally agree.
if you get a poor response from a therapist from that, I say, again, we're all people. Maybe they're having a bad day. Maybe they're
Mhm.
overwhelmed. Maybe they're really stressed and burnt out, which doesn't justify the way they respond to you if
Mhm.
it's poor. But, or maybe if you feel like that's kind of been the trend, maybe it's time to see if you can find someone else. Like,
Mhm.
um, because at the end of the day, in the ideal world, that's not the response you should be getting.
Totally. And again, it's so, so, so important that you feel like your physical therapist is someone you can talk to, just like you would want a regular therapist to be able to feel like you can confide in them and talk to them and all of that. It's important. And also, your PT should have an exact reason that they are giving you every single exercise. They should not be just like handing you a piece of paper and being like, I gave this the last 6 people too. Have a blast. They need to be tailored to you. If they take a piece of paper out of a file and then like write notes on it that are specific to you, I would call that tailored to you. But if they gave you and last 6 people the exact same sheet, that is likely not tailored to you. So There's sort of a balance there, go with your gut, but they should have an exact reason they're giving you exact exercises. Physical therapy, there is some trial and error involved, but in school, we were always taught, like, on freaking repetition, dose your exercises like a medical doctor would dose a prescription. You don't just go handing out 50 milligrams of X, Y, and Z willy nilly. You give every person, you take their height, you take their weight, you take all these other things into consideration, and you prescribe this much of this medication. The exact same thing is true for physical therapy. So sending you home with random exercises is not it.
Yeah, and especially again, kind of if you're feeling kind of on the fence about it, maybe standing is still a lot and that might be the flare up. So again, their job is to say, well, let's try these sitting options.
Mhm.
Let's maybe try some of these laying down options, which might not be as readily available or on like handout sheets. So if it is more of those
Mhm.
cookie cutter sheets, they probably don't have the laying down or sitting down options really. So
Mhm.
I drew a lot of stick figures
Me
and
too.
bad chairs and beds.
Mhm. I'm totally with you. And other things that are not vestibular rehab, Cawthorn Cooksey exercises and the Brandt Daroff. If you have been prescribed those, please see someone else. I'm just gonna say it across the board. That is not VRT. It is not customized to you, it is not specialized to you, and frankly, the research just does not back them up. They're not super helpful. People are like, "I've been doing them for weeks, and I notice no difference." It's not vestibular rehab. And also, everyone in the healthcare system has their specific job. The job of your medical doctor is to diagnose and treat you, likely with medications, because that is what they're taught in school, no fault of their own. They're not taught nutrition, they're not taught all the other things. The job of your physical therapist is to spend time with you. It is to prescribe you exercise and lifestyle changes. So if you are taking medication advice from your physical therapist and they're just like telling you to cut your pill in half or double your dose of something, no. Just like your medical doctor isn't necessarily the right person to prescribe you exercise. And so taking medical advice from the right medical professional is absolutely the right way to do that. And I know that sounds weird because we honestly place a lot of trust in our medical doctors a lot of the time. Some people really don't, but a lot of people really do. And I think it's important to recognize that, like, I take certain advice from a medical doctor, certain advice from a dietitian, certain advice from a physical therapist, certain advice from a speech language pathologist, an occupational therapist. Like, all of us go to school for a really long time to do a very specific thing. So just like you wouldn't take pill advice from your PT, you shouldn't necessarily take specific exercise advice from your medical doctor.
I know I've seen like I think I've seen the what is it Hawthorne or Cawthorn? Hawthorne.
Cawthorn,
Yeah. Is it with
Cawthorn
the
Cooksey.
C?
Yeah, Cawthorn Cooksey.
Okay. I always want to say it's Hawthorne. But I
No,
know
Cawthorn Cooksey.
I've seen maybe like people get that when there's like, they're still feeling like residual BPPV
Mhm,
symptoms and they aren't really testing positive on positionals. But again, sometimes that reasoning might be like, let's just try this for a little bit and see if that
mhm,
like knocks something loose that's maybe just like hanging out or something, or, just again, trying to use that as a movement type to help with a functional thing. But we can get into that more at the BPPV episode. But when people are like, I've been doing this for weeks or months, like this is the only thing I was given, I'm just like,
yeah,
well, let's maybe try some other things. If you like it, we can keep it, but let's maybe try some other stuff and see if you want to give this a pause. Like,
mhm,
so it's, yeah, I can't say it's great, but if that's what someone was given, I'm always a benefit of the doubt person, that I'd be like,
mhm,
maybe that's all they knew about because they didn't
totally,
get the type of background we had. And, this
mhm,
might have been coming from a place of, this is the most I know. And maybe that's how they ended up getting to this clinic instead. And if they've been doing it for months, well, it sounds like they're good at doing their exercises. Let's give you something else.
mhm,
But that should not be the only thing you're getting.
absolutely. Absolutely. Well, if you have more questions about whether or not you should be in VRT, what VRT is, what exercises you should be doing. We cannot prescribe you exercises unless you are our patient. If you have any of those types of questions, please let us know either in the comments below or shoot us an email or a DM. And know always that Dr. Jenna and I are here to help. We are vestibular therapists. We are licensed between the two of us in 8 different states. So if you do want to come and see us, please shoot us an email. Dr. Jenna is Jenna at thevertigodoctor.com and I am Madison at thevertigodoctor.com. We'd be more than willing to help you out with this. So, yeah, I think that's it. Thanks so much for listening.
Yeah.
See
Awesome.
ya.
Bye.
Bye. Thanks so much for listening today. Find me on Instagram at the Vertigo Doctor, Dr. Jenna at dizzy.rehab.therapist, and the pod at grounded.vestibular.pod. Remember to rate, review, and subscribe to our channel wherever you get this podcast. And if you're interested in working with us, try Vestibular Group Fit, the affordable, comprehensive program that focuses on movement, mindset, support, and education to take you from frustrated and dizzy to feeling in control of your vestibular disorder. Use code GROUNDED at checkout for 10% off your first subscription. Or we can work together one-on-one in California, Virginia, Minnesota, Maryland, New Jersey, New York, Wyoming, and Wisconsin. Your success story begins today. Dizziness does not have to be forever. Let's get you the right tools to thrive. Love ya, and we'll see you next time on Grounded.